So now there's a regular item on the agenda for these innovation symposium, which is the On the Couch segment with the Secretary and the Minister. So please welcome Jillian Skinner and Elizabeth Koff to the stage. Fantastic presentations though as well, aren't they?
We reckon they should be on the couch.
We can always invite them back up.
They offered.
Jillian, I just wanted, picking up on some things that happened yesterday, and we started off with childhood obesity. What's your thinking? And it's fine to have a whole of government approach, but it does require a local level bringing people to the party. What's your kind of thinking on that?
Look, I have to confess that was my priority. When the Premier was talking about having 10 priorities to start with, and he said to the Cabinet, I want these to be highlight issues where if people thought, well, if we've got 81% of our patients going through the ED within 4 hours, that will indicate that the rest of the hospital is working well. And I said, look, that's fine, but don't skew the whole system to the acute hospital. We're trying to send the messages about prevention and looking at the whole other part of the human, condition. And so that obesity was one of mine. And can I tell you that it's a very ambitious goal, but at a presentation that I was with the Allied Health staff at Sydney Hospital the day before yesterday, they told me they've got a whole body of work on this childhood obesity that involves family and community services, education, sport, a primary health network and health, and it's changed the way they work. It's changed the priority that they're putting into their work, and they're having real outcomes that will make a big difference. So that's the advantage, I guess, of having it in that top level Premier's priority. It brings all of those agencies and gives them an obligation to give it high priority. And a subcommittee of Cabinet, which I happen to chair, it's a social policy subcommittee of Cabinet, has a report on a regular basis on how we're doing. So it's changed the profile of those conditions. And
Elizabeth, it requires a sort of kind of broader view of the health system as well.
It certainly does. Look, some may not know, but I originally trained as a dietitian and spent many, many years counselling, advising on obesity on a one-on-one basis. One comes to the realisation then that it certainly needs the commitment of individuals, but there are far more numerous factors that influence the levels of obesity. And as yesterday's video from the endocrinologist from St Vincent's indicated, it does require personal commitment and discipline. However, there are a number of macro system issues that need to be addressed, and we touched on sugar tax yesterday, and what the Minister just described as what I call the meso system operating of the agencies coming together and collaborating to make the environment more conducive to enabling people to make healthy choices.
Clinicians, nurses, doctors, allied health practitioners want to do something, but they often think, well, what can I do? And one initiative that's been discussed, I don't know if it's been discussed in New South Wales, certainly in Queensland, is that every time somebody touches the health system, they're weighed. Is that a proposal here too?
Well, I was hearing, I don't know whether she's still here, Teresa Anderson was telling me that I think at one of their one of their Get Healthy days next year, every person that turns up at their hospitals is going to have, their weight, height, BMI. And I think, Teresa, all the staff are going to do the same. Did we get agreement on that?
Yes.
I don't know that there was real agreement, but it's that, making them think about it. I had one of my staff members went down to Canberra with her 2 young sons to take part in a basketball tournament, school tournament, and she said she was horrified at the overweight children who were the athletes. It's also about changing their own perception of what's got an ideal weight. And just following up from that our fabulous presentation this morning, there's some really interesting work that I know of that's going on in epigenetics about research into overweight mice, pregnant mice I think it is, something like that. Where the environment changes. And the impact that then has on their children. So this is work that starts way back there.
Now I think several jurisdictions have taken this on. It's clearly recognised nationally as a problem. What sort of And you're not going to get a sugar tax from New South Wales legislation. It's going to have to be federal legislation. And there's a strong belief in some, it's not just in the Liberal Party or the Nationals, it's also in the other side of politics. This is nanny state politics.
Yep.
To what extent can you convince federally to get the changes that not just New South Wales, Queensland, Victoria, Western, every jurisdiction wants?
Well, it's a matter. It's on the agenda for the COAG Health Ministers' Council. I'd say we're far from having a resolution, but at least it's being discussed. But Norman, I think back to just 20 years ago. Where were we in relation to tobacco control? We've got to start somewhere. And I think it'll be incremental, and the steps in, first of all, recognising that overweight and obesity is a national health problem, it's an international problem, will start slow but gather momentum and be incremental in what we can achieve.
Elizabeth, yesterday, changing tack, yesterday in your talk, the Minister referred to it as well, a major part of the health system is not just the P&L, if you like, the expense sheet, it's also the balance sheet and buildings and so on. And of course there's been some controversy in the press about that because you've got public-private partnerships and so on. Just lay that out for us in terms of how it's looking at the moment. In
particular, the public-private partnerships?
No, just in general, the approach to CapEx, really.
Yes, look, capital has been neglected for many years, and I think all credit goes to the current government for the extraordinary investment that we have had in infrastructure. And health infrastructure has done an extraordinary job in the capital program across the state. Some of the facilities that we do have are not well suited to contemporary practice, and I know from my many years in the health system that we talk about changing models of care, changing the way we conduct our business, and we're often constrained by the physical environment in which we operate. Over the past 5 years, we've invested approximately $1.4 billion per year in new capital developments. And when I started in the role, I had the opportunity to do a listening tour, and I think, got out and about to most districts. And one of the things that stands out to me, number one, the rural developments have been absolutely outstanding. The differentials between health outcomes between rural and city populations has been well documented, and largely that's a function of the access. The fact now...
You're saying buildings won't necessarily solve that?
No, but the buildings enable us to attract the clinical workforce that makes it appealing to work there. So going to Dubbo, going to Orange, going up the north coast to look at the developments up there at Coffs Harbour. It's absolutely amazing the services we can offer now in some of the rural areas on the basis of the infrastructure providing the amenity and facility to attract the clinicians to deliver the services locally.
Gillian, but part of that infrastructure, it's like wiring the house. You don't see it. It's not in fancy new building in Goulburn or Blacktown. It's the infrastructure. And we still have a health system based on faxing. We have a health system where specialists, where GP, it kind of melds into the integration conversation, where GPs are highly IT literate, but specialists have varying things on their desktop if they've got something on their desktop and aren't playing ball in the system. How, it's a federal problem, but it's also a New South Wales problem as well. How do we get that secure messaging backbone working better than it is?
Look, you're really talking about the tremendous investment that's required and that we've made and will continue to make in terms of IT intelligent buildings and systems within it, including the e-health investment in electronic medical records that can talk across hospitals and they're there. Or every patient who goes to a New South Wales hospital now has an electronic medical record, and they can be read across hospitals within their district and increasingly outside. And in some of our integrated care demonstrator sites, they talk to GPs. So we're getting there. It's not perfect yet, but by God, when I was first looking at this 10 years ago from opposition, because I'm passionate about this area, it was, never going to happen. Well, it is now. Electronic medications management making a huge difference. But you've got to build hospitals to make that possible. So that is one of the reasons why I'm absolutely wedded to our health infrastructure team and their approach. They try and build every building ready for this now, but into the future in terms of technology and capacity, so Wi-Fi enabled and everything else. And this was really telling. I took the Premier on a visit to the new Northern Beaches site, which is a PPP, just at the end of their groundwork completion. And we walked around the site. It was an ideal site to look at because it's got a sort of raised area. And you could look down and look at all of the cabling, look at the gas pipeline, look at the ponds that are under there for everything. It was astonishing. And I said, Premier, that is why when we start the money going into these projects, you don't see anything for the first year or even 2 years because of the sophistication of the early works and making those buildings fit for purpose and able to accommodate the new models of care that Elizabeth talked about.
And I want to bring, so talking about PPPs, an issue that we raised yesterday and I said I'd come back to today, and I'll ask Elizabeth first. I mean, if you look at Western Australia, we've probably got the best experience in this area with Joondalup, Bentley, which are PPPs, which are recognised as really quite successful. But there has been a huge learning process in Western Australia about the contracting process. Because if you get the contract wrong, you can get perverse incentives in and you end up with a model of the private sector which is about over-servicing and not necessarily the best care. Tell us just about as much as you can about the contracting process which ensures you actually get more public-oriented care in those places.
Look, we're fully cognisant of the issues around contracting and the importance of us having the capability and understanding to arrange the contractual arrangements so they are beneficial and seek to deliver the outcomes we want to deliver. I think our learnings to date too so far demonstrate it really is about being quite explicit about the outcomes we want. We don't want hundreds of KPIs that end up an arrangement in tracking KPIs and creating tension between partnerships. The most important things we're striving to achieve are really focusing on the clinical outcomes that we expect from the service delivery.
Presumably at a certain price.
Yes, and definitely we have a state efficient price, and where we negotiate between any proponent is always understood where we sit on the state efficient price. And also on the national agenda, it's quite explicit, some of the pricing with the nationally efficient price also. So we're very cognisant of what we'd want on the clinical outcomes. The second most important thing, and we had a meeting about this discussion yesterday, the service provider really needs to have a deep understanding and will be provided with that understanding of what the district requires. This isn't an independent hospital facility located in a district
part of a network
that has complete autonomy to do what it wants to do. It is a part of an integrated service network of the district that will have a prescribed role for the delivery of public care to all residents of that district.
No, sorry, yes, Sean.
Look, I mean, your question, Norman, about Western Australia. You know, the first enterprise we started in this is the Northern Beaches, and we went to Western Australia to learn from them. We actually engaged the person who led Joondalup and others over here as part of our negotiation. And you're quite right, they said to us there were things that were essential. And the first was, take your time to develop the contract. Both parties have to know exactly what's expected of them. It needs to be a win-win for all. There's not winner takes all, and the shared risk, and keep it going right through the whole project. And so that's what we've been doing at Northern Beaches, right through the contractual arrangements, conclusion, building, and in through the operation. There will be an ongoing role. We also learnt from the failure of the earlier very primitive model of Fort Macquarie, which was very different because there was no activity-based funding. There was no real transparency there where it is now. And in the latest request for expressions of interest that we've put out there, those are the kind of things that we will be looking at. We've gone to 4, have come back as being a lot of interest. The 5th not, so we've said no, we're walking away from that. But we'll end up at the end of this process, I hope, with 4 proven hospital operators with a track record in Australia that can deliver bigger, better, faster services than are there now. And just a la your last question, if there's potential for a private provider or a not-for-profit non-government provider to co-locate services that we wouldn't do with public money. So a GP clinic, more research capacity, co-located aged care, or even Medi-Hotel. There's really open season for a not-for-profit or a non-government provider to do those kind of things that we couldn't afford to do with just public funding.
So how does research and teaching fit into that private model?
The contract for Northern Beaches requires research and teaching as part of that contract.
One of the issues, just looking more broadly, just before we move on to something else, is, again, using West Australia as example, one of the problems of the Fiona Stanley Hospital has been kind of half pregnant. Public money, and then they put in a private provider to kind of run the nuts and bolts, and lots of turmoil inside. What lessons have you learnt from the Serco Fiona Stanley kind of experience, if any? Elizabeth?
Look, I think potentially the issue we had at North Shore represents a potential similar scenario, that if you don't understand what you're negotiating, if you don't have a good relationship with the service provider, and an understanding that you're not chasing them with clipboards for hundreds and hundreds of KPIs, the relationship is constrained and often not successful.
It's in the contract, really.
Sophistication in negotiation.
Yes.
Let's move on. One of the things you talked about yesterday, Elizabeth, was decision-making closer to the patient.
Yes.
But it's still decision-making often by somebody else for the patient, rather than a true shared experience, and giving a bit more, lowering that information asymmetry between providers and patients. What's the thinking about how you change that, apart from cultural change?
Look, it's a perennial challenge, but most of the evidence internationally really strongly suggests that if patients are meaningfully engaged in their care, the outcomes are far greater. And I think it involves having the dialogue about the potential benefits and risks of some of the options of therapy, and fully informing patients as to the expected outcomes.
How do you systematise that?
I don't know whether there's a tried and true recipe for systematising it. Culture, as you said, is one element of that. Some of the structural systems we have in hospitals, I think, may facilitate that also. But I think it does require the leadership of both the medical, nursing and allied health professions to be able to change the way we're viewing these things and really listen to the consumer voice in what we're doing.
Yes, look, I mentioned yesterday some of the projects that I'd chosen as a Minister's Excellent Award winners. The Cyber Rounds, the Interdisciplinary Rounds project at Orange Hospital was one of them, where you had every discipline, the nursing, doctors, pharmacists, and the patient and their family engaged in that ward round, which changed the outcome for the patient. It saved money for the hospital because they were there, the length of stay was reduced, etc. The patient got better quicker. That takes a champion, medical and clinical champions, as well as the leadership that recognises that. And then the reward should really be about sharing some of the gains financially that can be put back into the delivery of more health services there. Our integrated care strategy...
You're up for shared risk
Well,
models.
look, our integrated care strategy, I'll quickly tell you my integrated plum jam story, because to me this is tremendously illustrative of this. Integrated care is where we're working in partnerships through through our local health districts and local providers. In this case, it was at Cowra, with a GP practice out there. And there was a fabulous doctor, Dr. Roz, GP, mother of 4, 1 child on hip. She walks around the place, absolutely fabulous. I met her just after Christmas, where she presented me with a jar of plum jam. And she said, "This is from my patient who, for 20 years, has chronic disease. For 20 years, had been spending Christmas in hospital. But because he's now engaged in his own care plan with the GPs, the community nurses and everything else, was able to stay home. He went and picked his plums. He gave them to me. I made it into plum jam, and here it is." That, to me, was the benefit of doctors and the team recognising the value for individual patients, but for their satisfaction in seeing a much better outcome.
So just on the kind of that same track, how transparent are you willing the New South Wales health system to become so that consumers can actually make more intelligent decisions?
I think information asymmetry is part of the problem, and what we've been having the discussions over recent months. As I spoke about better value care yesterday, the safety and quality agenda is one aspect that's absolutely fundamental to the progressing, I think, well-informed consumers. Public reporting about performance around safety and quality is critical.
So across the standards? Across
the standards. And currently our focus, and the CEC has done an extraordinary job, and the system has responded very, very well to some key initiatives. But our focus primarily has been on incident monitoring across the system, and well-developed hospital systems with safety and quality systems actually tend to focus also on triangulating consumer complaints and understanding of what consumer feedback on their system is telling them, what the incidents are telling, and the culture of the organisation. Because recent events, even in Victoria, indicate with Djerriwarrh, you can be meeting all performance metrics and you can still have a run of adverse events that, when you dig a little bit deeper, really highlight some of the issues around culture and
let's just look at Djerriwarrh for a moment. For those of you who don't know, 11 perinatal deaths, probably 7 of which were preventable, and the review actually gave New South Wales a tick, suggesting that it was possibly less likely that you get a Djerriwarrh in New South Wales because you've got different ways of measuring safety and quality and publishing it. But can you put your hand on your heart and say there are no Djerriwarrhs in New South Wales?
I think that's part
Which is what keeps you up as a... keeps you both up.
And that's part of the discussion that the Minister and I have been having.
Yes, and look, we've put a lot of effort into being more open and transparent through the Bureau of Health Information and Clinical Excellence Commission, ACI. A lot of this information is actually already there through website access, but a lot of it's buried and so on. The consumer generally wants it in a more simplified, quick, easy way to read, and we're looking at doing things like that through the BHI. But I think because we have been a lot more transparent about what we do, people can find these things out. The real problem is things get taken out of context. Some of the recent incidents that have involved, the media's been asking me about it. They're plucking individual situations out of the ether, or real incidents. There's no doubt about it, but they're not typical of the experience of the great majority of the 2 million patients that are admitted to our hospitals every year.
So, talking about the media focus, say on just choosing something at random, oncology. But distracts from some major issues that are very difficult to deal with, such as mental health care. How do we get to a better place than we're at now?
Talk to the media. I started my life as a journalist. It distresses me enormously because all of the fabulous stuff we've heard about yesterday and today, these marvellous presentations from Marcel and Phil. I sat opposite Marcel at a function last night and said, oh, I think you're speaking tomorrow. People were blown away by it, but can we get the media to take a lot of interest, or the mainstream media? No. So it's a challenge. And for everyone in this room who's involved in innovation.
But we're fascinated by, the Marcel type stuff with genomics. But what about the people with severe and persistent mental health problems?
Yes.
I mean, that is a wicked problem.
Yes,
and
it is.
It keeps on bouncing back. And we're not that good either at treating people with high prevalence disorders. I mean, what's the plan?
Look, the Mental Health Commissioner's report, the Living Well strategy, we've articulated in that a fundamental shift in the way we want mental health services to deliver. The three key elements around that are the deinstitutionalisation of long-term mental health patients in New South Wales facilities, and
which requires a lot of community investment.
It requires a lot of community investment, which we are investing.
1,000 were in those institutional settings when we became the government. We got it down to 380 at the beginning of 2015, and down even another 100 if I remember.
Yes, we're 100 further down.
It's been relatively slow because you do have to encompass them with community supports, because remember the old Richmond Review, you would know, where they were just deinstitutionalised without the proper community supports, and this has been our total focus.
And strengthening the community delivery of mental health service, I believe, is a fundamental prerequisite.
Which is often disconnected from general practice.
It certainly is, and we're watching with great interest in the primary health network space as to how the changes in NGO funding to the primary health networks.
Just watching or actively involved in yourselves?
Well, they keep us involved when they want us to be involved, and they keep us excluded when not. But this occurs at the local level, and I think that's the most critical thing. We can articulate policy and strategy from a central office level, but it's about the relationships that are developed between the primary health networks and the local service delivery, and how we meet the needs of the population locally. Co-commissioning is something that we're discussing with the PHNs individually, depending on the nature of the catchment profile.
A good example of where a major improvement has been made is Wagga Wagga. I don't know if anybody's here from that service, but
Murrumbidgee always come to a good party.
This was a hospital that was been promised to be upgraded for decades, and the first stage of the upgrade was the creation of the new mental health facility, which is just phenomenal. So not only does it have a purpose-built acute capacity, but it then has the outreach capacity, so that there's a whole floor on it. It's really like step down, connection with the community, and telehealth, where they can outreach to all of the outlying areas. It really has been transformative for that district, and something that is really important, because it's a whole range of services. It's making sure the acute is there, but then the connections with support out into the community.
Could you please thank the Secretary and the Minister?
Thanks, Tom.